patients having angle closure glaucoma or any kind of glaucoma, all, all the patients and patients of the relative will be giving a complete screening for glaucoma. There is a strong evidence saying that more than 30 to 40% will lead to the family, and it is a hereditary disease. So the family history of glaucoma, it is very, very important. If we are, any grandfather asks if the children are not happy, we should not take it to subject. Even the grandchildren, chances of having glaucoma. So the family history is very, very common. And the next one is if you are 40 years and above, that is more than 40. It's not like only it occurs only in the early age. It may occur in the newborns also. Congenital glaucoma conditions also is there. But still, if there is a majority of the cutoff age, what we can say is that if you are 40 and above, where the presbyopic starts to occur, so in those conditions, if they are 40 and above, the risk factors of glaucoma is very, very important. And steroids. If the patient is having any intake of steroid, that is, we can tell the patient is having a long term for any skin disease. The skin, if you take the skin ointment and if you see, there will be some kind of steroids will be there. And if the patient is working on any kind of long term, any uveitis condition, patient will be putting on steroids, and some bodybuilders will be using steroids for their enhancement. So all these long term of steroids also will be good risk factors for glaucoma. And the refractive error, this is a condition where the myopic comes in a place. If the patient is a myopic, and if he changes of glasses and there is a gross changes in the myopic, that is, if a patient is getting to a refractive error checking of -1, and after 6 months and after a year, if you're going and again a refractive error of -3, it increase the gross increase of -2, then we have to take a serious look at the glaucoma, because the axial length plays a major role for glaucoma. So the myopia are more prone for the glaucoma. And next thing is trauma. If the patient if had any kind of a trauma, any injury or blunt injury or any kind of a trauma, RTA cases, if the patient is having subconjugal hemorrhage and extending towards the posterior segment also, we have to check digitally how the pressure is at the time of incident also, because that will gives you an idea of whether the patient is having an early sign of glaucoma or not. If the patient is treated with some kind of steroids and the patient is having angle closure glaucoma or any kind of glaucoma, and the very important thing all is the patients and all the patients of the relative will be given a complete screening for glaucoma. Major role. There is a strong evidence saying that more than 30 to 40% will lead to the family, and it is a hereditary disease. So the family history of glaucoma is very, very. So what is the alarming symptoms if they consider as a glaucoma? First one is colored halos. If a patient complains to saying that if he can able to see a bulb and there is a like a rainbow color of light which is throughout the light, called as colored halos, that is one of the major sign for the glaucoma. This is very, very important for alarming situation. When the patient is complaining, say that immediately we have to take a complete evaluation for glaucoma. And the second one is painful red eye. If a patient comes to you with a lot of pain and a lot of with a lot of pain, patient comes to you, immediately when we check the IOP, it will be nearly shooting more than 40 to 50. And when we do examination like a gonioscopy, when we do, it will be angle closed. So there's a condition called acute angle closure glaucoma. So patient will come with a severe pain, patient will have a red eye, patient can't able to even sit, and he can't able to lie down, he can't do anything. So this is the major two alarming symptoms where the colored halos and painful red eye becomes unable to appreciate. We have to do a complete glaucoma evaluation. And the other symptoms, the patient comes with only the pain but doesn't have any kind of redness, or patient have only the redness but doesn't have any pain and headache. This is a one reason where the intraocular pressure, if the rise in intraocular pressure, may chance it slowly increases, and frequent changes of glasses. Actually, whenever a patient having frequent change, myopic or hypermetropic, when there is a frequent change, like every 3 months or 4 months, every 6 months once, we have to check for complete evaluation. So what are the myths actually? For the patients, there are a lot of myths going on. So glaucoma affects only the elderly. We say that it affects more than 60 years and above. Those are the myths. And actually facts is, there is a condition called congenital glaucoma. It occurs in the newborn babies also. And there is secondary glaucoma, secondary conditions. If the patient is undergone any kind of vitreoretinal surgery, if they are long time of steroid medications, and if the many of the people will undergo any kind of trauma, so there are secondary conditions. So this is not affects only the elderly people; it can affect anyone. So the another myth, what they're saying that glaucoma shows any obvious symptoms. You will have like a cataract. You can't able to see all those. It shows glaucoma. It's not actually at early stage of glaucoma. There won't be any signs and symptoms. Only on a routine OPD examination alone, you can able to appreciate whether the patient is having glaucoma or not. The next myth, what is that? The glaucoma testing is very painful. Actually, the glaucoma testing is painless. It doesn't have any kind of intervention, and even the investigations regarding the doing a HFA, perimeter, OCT, and fundus photograph. These are all non-invasive investigations. You won't have any kind of contact. We won't do anything. We just scanning with the help of the scanning. We'll do the investigations. The next myth, what is that? Once you have a glaucoma, nothing can be done. There is a myth. This is one of the major questions we'll be asking to all the glaucoma consultants, saying that if you have glaucoma, nothing can be done. Right? We can be treated at the earliest stages. This is the most important thing. We can treat. If you're suggesting on routine basis, if the patient is supposed to be diagnosed as a glaucoma patient, when we start treating with the patient, this will help in the patient visual security, we can say that, and it slows the progression also. And we had a family issue. We explained about the risk factors of glaucoma. In the midst of glaucoma is inherited, and since no one in the family has glaucoma, so I won't get the disease. It's not at all like that. If no one has a glaucoma also, while if you're nearing a 40, you should undergo a complete glaucoma evaluation, because glaucoma can occur for anyone. So these are the main myths and facts, and this is regarding my awareness, the main awareness for the glaucoma. Since this is the second leading cause, so we should not take lightly the glaucoma conditions once it has been established, and if it is on the latest stages of the disease, it is very painful actually whenever you can't able to appreciate the peripheral field of defect, because it mainly affects the peripheral field of defect, and it will gradually goes in the tunnel vision like appearance. So this is my topic, awareness of glaucoma, and next my colleague Dr. Suganya ma'am will be presenting on the what are the workup, what we do when a patient comes to the glaucoma clinic or patient comes to the ophthalmic clinic, what we do, what are the tests we do, and what are the investigations we do, and what are the interpretations. So Dr. Suganya ma'am will explain it. And thank you one and all for this opportunity, and thank you.
Thank you, sir. That was indeed a fascinating and informative speech. Now, I would like to call Dr. Suganya, ophthalmologist, to talk about glaucoma workshop.
Good afternoon to one and all. Thank you so much for having me here. I'm Dr. Suganya, Senior Resident, Department of Ophthalmology from ACS Medical College. So before we proceed into how we work up on glaucoma, let me give a brief introduction on glaucoma and its types. Glaucoma is a condition that damages the optic nerve, the health of which is vital for a good vision. So this damage is often caused when abnormally high pressure in the eye, producing a characteristic optic disc changes, visual field changes, with or without associated with raised IOP. As we all know, glaucoma can occur at any age, but it is more common in older adults. Usually, glaucoma have no warning signs, the effect of which is so gradual that you may not notice a change in vision until the condition is at advanced stage. Because vision loss due to glaucoma can't be recovered, it is important to have a comprehensive eye examination of all the clinic patients to have an early diagnosis and early intervention to prevent the end stage of the disease and complete vision loss. The glaucoma can be classified into two main types based on the appearance of the iridocorneal angle. So what is iridocorneal angle? It is the angle or space between the attachment of iris with the cornea. If the angle is open and normal in appearance, it is called as open angle glaucoma, and if the angle is closed, it is called as closed angle glaucoma. And these two types are further classified into two other types, that is primary and secondary, based on the presence of any causative factor. If there is no associated causative factors present, it is called as primary glaucoma, which can be open or closed. If there is a presence of any causative factors, then it is called as secondary angle glaucoma, secondary glaucoma, which can be again open or closed. For example, as Sir said, steroids can induce glaucoma. Long-term usage of steroids, either oral or topical, can induce glaucoma. Presence of any pseudo-exfoliations or pigment dispersion blocking the aqueous outflow pathway, raising the intraocular pressure, can cause glaucoma. Lens-induced glaucoma, where swollen lens or lens particles blocking the aqueous outflow, can cause glaucoma. So our glaucoma workup is to find out the risk factors of glaucoma, types of glaucoma, that is open angle or angle closure, and primary or secondary, and characteristic changes of glaucoma, that is typical optic disc changes, visual field changes, and raised IOP to confirm it as a case of glaucoma. So how do we do that? By forming a workup plan, by taking a proper, detailed history, examination, and relevant investigations. In history, the history is constructed in such an orderly manner so that you extract a detailed history without missing out any relevant information. We start with the general information where we emphasize on age and gender of the patient. As we know that glaucoma can occur in any age group, but if the presentation is seen at the time of birth, you call it as congenital glaucoma. If the presentation is between 1 to 3 years of age, it is called as infantile glaucoma. If the presentation is seen more than 3 years of age, it is called as juvenile glaucoma. And if the presentation is seen more than 40 years of age, you call it as adult onset glaucoma, which is the most common type of glaucoma. In gender, again, glaucoma can occur in both males and females, but studies have shown that the incidence of open angle glaucoma is more commonly seen in myopes, and incidence of angle closure glaucoma is more commonly seen in females. The next is we record is the chief complaints. See, the clinical features of glaucoma are so characteristic for each type of glaucoma so that you can come to a probable diagnosis of what type of glaucoma it is by history taking itself. For example, when you take open angle glaucoma, it is usually asymptomatic until late stage, and it is always an incidental finding during routine ocular checkup. In case if the IOP is so high and have a secondary causative factor, that time the patient may present with eye pain, redness, and gradual decrease in the vision, which shows a diurnal variation depending on the IOP peak. So what is diurnal variation? It is change in the intraocular pressure with the time. Normally, the IOP is high in morning and decreases by evening, and it is usually less than 5 millimeters of mercury. And this is because of the plasma cortisol level. When this variation is more than 8 millimeters of mercury, then you can suspect as a case of glaucoma, during which the vision also decreases with increase in IOP and with time. The patient usually gives a frequent changes of glasses, especially presbyopic glasses. Why? Because in raised intraocular pressure, there is a constant pressure on the ciliary muscle and its nerve supply, failing the accommodation process and making the patient difficult with the doing near works. Contrary to this type of clinical features of open angle glaucoma is an angle closure glaucoma, which is an acute and emergency condition and presents with a sudden onset of unilateral decrease of vision with severe redness, pain, side headache associated with nausea and vomiting. And these symptoms can be precipitated by watching TV or reading in a dark room. So what happens in dark room is that pupil dilates. So when the iridocorneal angle is narrow, pupil dilatation can make the angle even more narrow, blocking the iridocorneal angle, the aqueous outflow, and raising the intraocular pressure, during which a corneal water enters, the aqueous enters into the corneal layer, causing corneal edema, which affects the main function of the cornea, which is a refractive. As we all know, that cornea is a main refractive medium. So because of corneal edema and water in the cornea, instead of refraction, the light gets dispersed, resulting in perception of glare and colored halos. What is glare? Glare means intolerance to bright light, and color halos is something patient perceives when he sees a point source of light. And it is appreciated as a ring of halo around a point source of light with two colors, red or blue, one inside the halo and other outside the halo. The next we record is a history of presenting illness, where we asked about the onset and progression. Onset as sudden or gradual onset, and progression whether it is slow or rapid of each symptom to know the severity. If a patient is already a known case of glaucoma, it is very important to record the treatment history, including the dosing, any allergy, and effectiveness of treatment by IOP response, which will help us to stop the drug in case of any allergy or have an alternate or add-on therapy to improve the effectiveness of treatment. It is also important to collect previous IOP records and visual field records to study the progression of the disease. Next history which we asked is a history of past ocular illness, where we ask about any history of ocular trauma to rule out angle recession glaucoma. So what happens in ocular trauma is that there occurs an injury to the anterior chamber angle. That causes injury to the trabecular meshwork. So trabecular meshwork has minute openings through which the aqueous exit out of the eye. So what happens after the injury is a healing process. As a healing process, fibrocytes and collagen gets deposited. So because of too much of deposition of these cells, trabecular meshwork undergoes fibrosis, closing the openings in the trabecular meshwork, causing the aqueous outflow to get blocked, raising the intraocular pressure, and causes glaucoma. And we also inquire about any use of glasses, because information on myopia and hypermetropia, studies have shown that myopes have greater incidence of developing open angle glaucoma, and hypermetropes are at high risk of developing angle closure glaucoma. So what happens in myopia is that the eyeball is larger, stretching of eyeball happens, the structures get stretched, and so does the trabecular meshwork. So stretching of trabecular meshwork leads to injury. As an injury or after injury, healing process takes place and deposition of fibrocytes and the collagen gets deposited, closing the trabecular meshwork, making the aqueous outflow to get blocked, raises the intraocular pressure, development of open angle glaucoma. So what happens in hypermetropes? Hypermetropes generally have small eyeball, and so the structures and spaces inside the eyeball is small and narrow, making them more prone for an angle closure attack. The next we inquire about is the surgical history. Any type of surgery starting from cataract, retinal surgery, corneal transplantations, or any laser procedures, because they can be associated with the incidence of glaucoma as a complication in the post-operative period. Next is the history of systemic illness, where we inquire about systemic conditions like hypertension, thyroid disease, diabetes, vasospastic diseases like migraine, acute blood loss, and Cushing's syndrome, where the blood corticosteroids level will be high. As we know, steroid induces glaucoma. We inquire about these systemic conditions which is associated with glaucoma, and should also inquire about cardiovascular disease, renal disease, and bronchial asthma before we take a decision on anti-glaucoma medications. For example, patients with cardiovascular disease and bronchial asthma, we usually do not give an add-on therapy with which can induce glaucoma. For example, systemic beta blockers, steroids, drugs inducing angle closure attack like atropine, anti-Parkinsonians like carbidopa, levodopa, antidepressants, bronchodilators, etc. We should also inquire about any local or systemic hypersensitivity or allergic reactions to ocular or systemic medications. For example, if a patient is allergic to sulfur drug, carbonic anhydrase inhibitors, which is used as an anti-glaucoma medication, should be avoided. And any hypersensitivity reactions to glaucoma medications should be taken so that we don't include that particular drug in the current treatment regime. The family history of glaucoma is also very important because glaucoma tends to run in families. So this is the history taking with which we will be able to get information on risk factors of glaucoma and types of glaucoma. So next we move on to the examination, where we do a general physical examination and ocular examination. In general examination, we look for systemic conditions with obvious physical presentations that is associated with glaucoma. For example, neurofibromatosis, which is characterized by multiple small lumps of neurofibromas in the body. Sturge-Weber syndrome, characterized by pink or red birthmark called a spot vein stain in the face. Carotid cavernous fistula, which is presenting as a pulsating type of bulging of eyes called as proptosis, and thyroid-induced bulging of the eyes called as exophthalmos. The next we move on is to the ocular examination, where we start with assessing the best corrected visual acuity. So the visual acuity can be reduced in glaucoma due to three things. One, because of the optic nerve damage. Second, because of the corneal edema. And third, because of the ciliary muscle, constant pressure on the ciliary muscle and accommodation failure. And information on myopic and hypermetropic, because we know myopes have greater risk of developing open angle glaucoma and hypermetropes having higher risk of developing angle closure glaucoma. The next is the anterior segment examination using slit lamp. In open angle glaucoma, most of the structures will be normal except anterior chamber depth, which will be open, and pupil showing relative afferent pupillary defect. So what is relative afferent pupillary defect? It is also called as Martha's gun pupil, which is elicited by swinging flashlight test. When we throw a light, pupil instead of constriction, it dilates because the optic nerve is damaged in glaucoma, and we know optic nerve is an important afferent nerve for light reflex. So how an eye looks like in acute angle closure attack. The eyeball may look small in case of hypermetropia. Conjunctiva, because of inflammation, can show circumciliary congestion, that is congestion around the limbus. Cornea, we know an acute attack in raised IOP, it will be daisy because of corneal edema. AC will be shallow and pupil in mid-dilated state. So how do we assess the anterior chamber depth clinically? One by pen torch and other by slit lamp. So in pen torch, we throw pen torch obliquely from temporal to the nasal side of the cornea. When the anterior chamber depth is normal and it is open, the light traverses from the temporal to the nasal side without any obstruction. When the AC is shallow, the light pathway is obstructed, and this is in a formation of iris shadow in the shape of eclipse, and this is called as eclipse sign, and this test is called as iris shadow test. So how do we assess the anterior chamber depth using slit lamp? We can grade it, and the grading is called as Van Herick's grading. A narrow beam of slit is projected on the peripheral part of the cornea as near as possible to the limbus, so which will result in the formation of a slit image on the cornea and a slit image on the iris. The width of the anterior chamber angle is assessed by assessing the distance between the slit image on the cornea and slit image on the iris, and compared with the slit image on the cornea, which is usually taken as 1. If the slit image, the distance between the corneal slit image and the iris slit image is equal to that of the corneal slit image, which is like 1:1, then it angle is considered as open and it is graded as 4. If the distance between the corneal slit image and the iris slit image is half to that of the corneal slit image, again the angle is open, no problem, and it is graded as grade 3. If the distance between the corneal slit image and the iris slit image is 1/4 and compared to the corneal slit image, it is considered as moderately narrow angle and it is graded as grade 2. If the distance between the corneal slit image and the iris slit image is less than 1/4 and compared to the corneal slit image, it is considered as grade 1 and the angle is very narrow. So grade 1 and 2 is a very acute condition, it's an emergency condition where we have to intervene early, otherwise the patient can go for spontaneous closure at any time. So how the next is the assessment of the anterior chamber angle using by gonioscopy. So what is gonioscopy? Gonioscopy is a biomicroscopic examination of the anterior chamber angle using a device called as gonio lens, which is used to divert the light beams. So various types of gonio lens, like 1 mirror, 2 mirror, 3 mirror gonio lens called as Goldman gonio lens, and we have 4 mirror gonio lens called as Zeiss gonio lens. So this is how the angle structure looks like when we see through a gonio lens using slit lamp. And the structures seen from posterior to anterior are the root of iris, ciliary body band, which is seen as a gray body band. Anterior to the ciliary body band is the scleral spur, which is seen as a white line. And anterior to the scleral spur is the pigmented trabecular meshwork, which is seen as a brownish line. And anterior to the pigmented trabecular meshwork is the Schwabe's line, which is a thin fade line. When all these four structures are present, means the angle is open and it is graded as 4. When only 3 structures are seen leaving the ciliary body and only scleral spur, anterior trabecular, pigmented trabecular meshwork and Schwabe's line are seen, means the angle is also fine, quite open, and it is graded as 3. But only 2 structures are seen, that is pigmented trabecular meshwork and Schwabe's line, means the angle is moderately narrow and it is graded as grade 2. And only one structure is seen, like Schwabe's line, means the angle is extremely narrow and it is graded as 1. This is an acute condition which we have to intervene because it can go for spontaneous closure at any time. And this grading system of anterior chamber angle using gonioscopy is called the Shackel's grading system. So the next is the fundus examination of the optic to document specific optic disc changes which we see in glaucoma. So before we go into a study of how optic disc looks like in glaucoma, let us see how a normal optic disc looks like. This is the optic disc in the retina, which is where all the retinal nerve fiber layers from all retinal quadrants they converge to form the optic nerve head, from which the optic nerve fiber continues as optic nerve to the brain. The diameter of the optic nerve is 1.5 mm. It has a central depression called as optic cup with a diameter of 0.3 to 0.4. The optic cup consists of lamina cribrosa, which is a slit-like opening through which the central retinal vessels arise and divide and supplies the retina. It also gives way to the optic nerve bundles to continue further as optic nerve to the brain. The region between the optic cup and the disc margin is called as neuroretinal limb, and normal cup disc ratio is 0.3 to 0.4:1 of the total optic disc. So what happens in optic glaucoma is that there is a raised intraocular pressure, and that pressure is exerted on the optic nerve. The optic nerve stretches, resulting in marked cupping of the optic cup, that is more than 0.4. So because of marked cupping and enlargement of the optic cup, which may reach up to the disc margin, there is thinning and notching of the neuroretinal rim between the optic cup and the disc margin. And because of the enlargement and stretching of the optic cup, the retinal vessels are shifted nasally, causing nasal shifting of the blood vessels, with appearance of blood vessels getting broken off at the disc margin called as bionating sign. And because of the too much stretching, the lamina cribrosa slit-like openings, which is present in the lamina cribrosa and the optic nerve, the optic cup becomes visible, causing laminar dot sign. With the progression of the disease, the entire optic disc becomes wide, deep and excavated, called as provocative optic atrophy, which is the end stage of glaucoma, where there is complete loss of vision with no light perception. So with this, we are finishing the examination. Next, we move on to the investigations, which we start with measuring the IOP. The normal intraocular pressure is 10 to 21 millimeters of mercury. We have two types of we measure IOP using tonometers. We have two types of tonometers in ophthalmology. One is indentation tonometers and another is applanation tonometer. Example for indentation tonometer is Sharp's tonometer, and example for applanation tonometer is Goldman applanation tonometer, commonly called as GAT, which should be preferred over indentation tonometer. So what is the technique? So here we anesthetize the cornea with the 4% xylocaine or proparacaine and stain the cornea with 2% fluorescent strip, and patient is made to sit in front of the slit lamp. And the biprism, which is mounted in the slit lamp, is advanced forward till it touches the apex of the cornea, like this. And then we see through the slit lamp under cobalt blue filter, where we can see photofluorescent semicircular mires like this. The application force in the slit lamp is adjusted so that the inner edge of the 2 miles just touches. This is the end point. And the IOP is determined by multiplying the dial reading with 10 to obtain intraocular pressure in millimeters of mercury. In the initial stages of glaucoma, the intraocular pressure may not be raised permanently. Instead, there is an exaggeration of normal diurnal variation. Therefore, repeated observation of intraocular pressure every 3 to 4 hours is required for 24 hours. A variation in intraocular pressure of more than 5 millimeters of mercury is suspicious, and over 8 millimeters of mercury is diagnostic of glaucoma. The IOP that we are measuring is plotted in a graph like this, having time in the x-axis and pressure in the y-axis. In advanced stage of glaucoma, IOP is raised permanently about 21 millimeters of mercury, where we need not do this diurnal variation test. The next is the provocative test. Water drinking test is the most commonly applied test. Provocative tests are usually done to diagnose early type of glaucoma. And in that, water drinking test is the most commonly done test to diagnose early primary open angle glaucoma. The water drinking test is based on the fact that glaucomatous eyes have greater response to water drinking. What happens when you drink water? Water enters inside your blood, and from blood it goes to your eyes. Normally, when the aqueous outflow is normal and it is open, the water exits out. But when the aqueous outflow is blocked, it doesn't exit out. It gets collected inside your eyeball, raising the intraocular pressure. So this theory is used in water drinking test. So here we make a patient have an 8 hours of fasting, and then we measure a baseline IOP. And then we ask the patient to drink 1 liter of water, and then we measure IOP every 15 minutes for 1 hour and see the variation of the difference of IOP. If the difference in the IOP from one time measurement to the other time measurement is more than 5 millimeters of mercury, it is considered as suspect. When it is more than 8 millimeters of mercury, it is considered as clear-cut case of glaucoma. For diagnosing primary angle closure glaucoma suspect, that is an early stage of angle closure glaucoma, the best and physiological test employed is the prone dark room test. So here we make the first we measure the baseline IOP and make the patient lie in a prone position so that the lens moves forwards in a dark room so that pupil dilates with eyes open for 1 hour. After 1 hour, the IOP is measured. When the difference is more than 8 millimeters of mercury, it is diagnosed as primary angle closure glaucoma suspect. The next test which we do is the pachymetry, where we measure the central corneal thickness, because the central corneal thickness is very essential in the workup of glaucoma, because the central corneal thickness is closely related to the intraocular pressure, because a thicker cornea can overestimate and give a false high IOP, whereas a thinner cornea can underestimate and can give a false low IOP. So therefore, it is very important to give a correction factor when the central corneal thickness is less than 545 microns and more than 600 microns. The correction factor is for every 10 micron variation in the central corneal thickness, the IOP varies by 0.7 millimeters of mercury. The next is the perimetry, where we assess the visual field defects using automated perimetry or Humphrey's field analysis. The visual field defects in glaucoma is initially observed in the GONIOSCOPY area. It is the area which is nothing but 10 to 20 degrees from the fixation point. And this is a blind spot which depicts the optic nerve head. The earliest and significant visual field change in the glaucoma appears in the GONIOSCOPY area, either above or below the midline, called as paracentral scotoma. Scotoma means non-seen area in the visual field. With the progression of time, this paracentral scotoma can join with the blind spot, forming a sickle-shaped scotoma called as cedar scotoma. So with the passage of time, this cedar scotoma can extend above and below the horizontal line to reach the horizontal line, forming an arcuate scotoma called as superior or inferior arcuate scotoma. With the passage of time, These two scotomas, that is above superior and inferior arcuate scotoma, can join together and form a ring scotoma or double arcuate scotoma.